Hello. Hi, Dr. Bulte. Thank you so much for joining us tonight. I appreciate it. Um, I'm Jackie Criswell, and I'm with The Cure Starts Now. Um, like I said, thanks for joining us to talk about your research. I do want to say before we get started, on behalf of the 28 foundations of our DIPG DMG collaborative, as well as the 58 chapters of The Cure Starts Now, we are awarding you a grant of $100,000 for your research.
Wow,
Uh-oh. Keith,
that's
lean
amazing.
forward. Lean
A hu-
forward some.
$100,000.
$100,000. Yes, I
Oh,
know. And I think Keith has a big check he's trying to show there, but your
yeah, I
background
saw
might be
that, but
messing it up.
it
It's
disappears as
not
soon.
showing up.
No, I saw part of it. I saw the good part of it. That's amazing. Well,
Well,
thank you so much. I,
There you go.
I,
there it is.
I
There it
want,
is.
I want to thank you for considering my application. I have to say, I don't have too much experience with these kind of foundations. I have seen Keith, you testifying about rapid authorization of drugs and in Ohio with J.D. Vance back then, and your other interviews. I haven't heard of your organization, and I was sent this opportunity by the Johns Hopkins fundraising people. They were aware we were moving into this area with diagnosis of brain tumors, and thank you so much for this. And I'm extremely grateful. Thank you.
Well,
Well, and
we're
we
very excited. Oh, excuse me.
well, and we appreciate it as well. I mean, it's nice to see these grants, especially these novel projects like yours.
Mm-hmm.
And yes, I'm Keith Esserick, obviously with the Cure Starts Now. So
Mm-hmm.
great to make the connection with you. And frankly, it's rather intriguing to learn a little bit more about your grant. But before we jump into that, I want to introduce Rachel, who also wants to offer her congratulations.
Hello, my name is Rachel, and I'm the Research Support Coordinator at the Cure Starts Now. And congratulations on your grant. It certainly looks very innovative, promising. So just want to offer you my sincere congratulations.
Thank you.
And
Mm-hmm.
yes, of course. And so again, congratulations on this grant titled Imaging of DMG Stem Cells using Manos Weighted Chest MRI.
Mm-hmm.
And we would love to just know a little bit more about maybe the story of how you decided to pursue this research and what its significance is for patients and for clinicians.
Absolutely. And I realize the imaging stuff is very technical to explain, in layman terms, but it's a kind of MRI. Now, how this started is I have been imaging stem cells for a very long time. When I moved to Hopkins, the idea was to do stem cell therapy for regenerative medicine. This was a new area about 20, 25 years ago. People could inject cells in the brain to repair Parkinson's disease or stroke or in the heart, to repair myocardial infarct. And in the old days, we used magnetic labels. So we put in some magnetic small particles that would show up on the MRI. Now, I had a very smart postdoc about 5 years ago who followed up on another paper that we showed that tumor cells may have a different sugar makeup on their outside cell surface, and um, and looked at stem cells if they also may have this different sugar makeup because stem cells have a lot of similarities with cancer cells. They carry the same, the old days we called it carcinoembryonic antigen, CEA, the same markers because they divide very fast, stem cells and cancer cells, a lot of similarities. So we had a paper in a good journal on bone marrow mesenchymal stem cells that have that special sugar makeup. And so we could image for the first time cells that were not labeled by their native properties. And then, as a follow-up, we heard about the cells that drive that glioma aggressiveness, the cells that show up after radiotherapy, the cells that become recurrence, those guys we need to get, right? We need to see them. That those glioblastoma cancer stem cells, which are the bad guys, are not of neural origin. They're of that mesenchymal origin. So they're more like coming from some kind of support cell. Anyway, so we looked at their sugar expression, and lo and behold, they had all these mannose on the surface. So mannose is a kind of a glucose molecule. It's very important in biological signaling. A lot of cells bind to it. So we thought, can we image those cells with our technique, which is called mannose imaging? So we tested different cell lines, very aggressive ones that kill mice within 2 weeks. Similar cells, non-aggressive, mice survive for 90 days, and we saw all these differences in contrast. And yeah, so we were excited about it. We have a paper on that, nearly accepted in a good journal. And on top of that, at Hopkins with my colleagues, clinical colleagues, also at the Kennedy Krieger Institute, which is primarily a pediatric brain institute, um, especially for rare genetic diseases that most neurologists have never seen. These incidences, 1 out of 100,000, like Rett syndrome. Very, they call it vanishing white matter disease, terrible diseases. And that group with my colleagues is imaging kids with brain tumors using conventional methods. And I already teamed up with that. And in the grant application, I showed that image. We have done 2 patients with this technique, and it looks beautiful. And it's very simple. You're already doing MRI, so why not adjust this and throw this in for another 10 minutes? And then the whole goal is to predict how aggressive this tumor is. If they have a lot of cancer stem cells, it's not like wait and see. You want to, be aggressive if there's a lot of that, especially after radiation therapy. You want to continue following up. So that's that. And the other thing is the resection of surgery. It looks like it's very precise for the delineation because current MRI techniques often overestimate a little bit or underestimate the resection area. So that is the overall picture. And also, as I'm a PhD biologist by nature, and I'm interested, what is that mannose doing? Can we do something to block that mannose or develop drugs or something? I'm interested in the biology behind that other than a diagnostic imaging. So that's the impact. I hope that we have a technique. Okay, we can use
Great.
MRI to diagnose and call it in the old days stage 4 glioma, GBM. Once you're there, this comes in. How bad is that bad one? It's already bad, but how bad? I mean, is it going to take 2 months? Is it going to take a year or 18 months? Something like that. Is
Great.
that a little bit the overall picture? Is that,
Yes.
yeah,
Thank you.
okay.
Thank you so much for sharing. That was helpful. And congratulations again.